to kick things off today, my name is Julia Kelly. I am our Senior Manager of Application Enablement here at Arcadia, and I'm going to be talking about the concept of provider attribution in healthcare, with a specific focus on really how we work with organizations to ensure that their attribution strategies are appropriately aligned with their population health management and value-based care contracting goals, and that they're all set up for success. So wanted to start off by really digging in and level setting on what it is that we're talking about when we say attribution. This is something that really, when we work with our clients, effectively what we're trying to do is build a cause and effect model that can define relationships between patients and providers within the context of the interactions that they share. It's something that, in our experience, requires a deeply data-driven approach to be successful, because if you really think about it, a patient's utilization history, their condition history, the way that they navigate care delivery systems, the various claims and clinical data points that they generate can vary quite substantially. So it's really important, the organizations that we work with, that they have both a strategic and also scalable way of, first and foremost, collecting all of that assignment-oriented data and then synthesizing it in a way that allows them to really reach conclusive decision points about what attribution should look like and how that can best align with, as I said to start, pop health management and value-based care contracting goals. What we've got across the right-hand side here are what we consider to be just some of the key pillars of attribution. First and foremost, it's pretty intuitive, but attribution is fundamentally about assignment of responsibility, right? I've got one specific patient, and I need to think about what one specific provider is really best suited to align with that patient and take on responsibility for their care. Sounds straightforward. It's a one-to-one alignment, but in reality, it's not straightforward at all, because if you think about it, there's actually a really broad landscape of stakeholders that in some way have a level of engagement with patient care. There's obviously the providers that are directly rendering the services, but those providers are supported by care teams who may or may not have some degree of engagement with the patient as well. Those care teams are employed by practices, hospitals, other care delivery facilities, and the facilities are even in turn, if you sort of take a level up, overseen, monitored, managed in some way by health systems, networks, ACOs, even sort of monitored at some capacity by payers. So in that broad sort of convoluted landscape of stakeholders, finding the one person that is really best suited to actually drive positive patient outcomes and success can be really tricky, but that's obviously the end goal. And when I talk about success, obviously in bullet 2, once you do pick that person that is relevant for assignment, they are going to be the ones accountable for care quality, right? They're going to be driving improvement in outcomes. They're going to be boosting patient satisfaction, making sure that patients are adhering to care best practices. So again, that assignment of responsibility step is so critical, making sure that the person that you pick is not just kind of tangentially related to the patient, but actually, again, supported, informed, educated to drive those improvements in outcomes. And then if we take a little bit of a step back from just that patient-centric care, those outcomes are very often tied to performance measures, right? So understanding, once you've sort of selected that provider, making sure that they are, again, appropriately aligned with the measures or metrics that you've actually set as an organization, because you obviously want to, again, pick the provider that's best going to set you up to succeed in your reporting goals and contracting. And final bullet, those reporting goals and contracting are often high stakes because in value-based care models, they're typically tied to payments, right? Providers are getting incentives, facilities are getting incentives. So again, if you kind of take a step back, there's patient-centered care and there's also high financial stakes to all of this. So we want to make sure that we really get it right. So takeaway from this slide, attribution is not simple. It is can be a little bit arbitrary. There's no one source of truth. Can mean different things to different people at different points in time, but it is something that can be made a little bit easier depending on the tools that you use and the approach that you take. So as I said, transitioning into the approach itself, when we work with clients, we sort of do our initial discovery calls. I like to think of this almost like a funnel. At the start of an engagement, you really need to take a step back and think about what are the full scope of data points that I have available to me that are related to assignment in some way, because there are a lot. There are the intuitive ones that we refer to as sort of supplied assignment. So assignments that you are getting directly from some sort of external body, like someone has made a decision, looked at data and said, this is the assigned PCP. So those are variables like plan assignment here. A plan has given me a list. These are the patients, these are the providers, these are the assignments that I've decided are logical. That can be really helpful. It's kind of the closest thing to a source of truth that a lot of our clients have. Helpful when someone else makes the decision for you, obviously, but plan assignments are also fallible. They can lag. You could be assigned to someone that you've never actually seen. So a lot of clients will also rely on supplied assignments coming in from EHRs, which are also very helpful. They are updated usually more frequently in real time than plan assignments, but also not a perfect source of truth. We could have clients where patients are present in multiple EHRs and the EHRs don't line up. So throws a little spanner into the works in another instance where you'd want to take another step back and think about that third bucket of assignment information, which we refer to as derived assignments. So this is really a supplemental level of information where, when you work with a vendor like Arcadia, we can pull in those additional data points around utilization history and say, who is my patient actually seeing? What encounter data do I have? Are they having specific kinds of encounters tied to primary care CPT codes or maybe specialty CPT codes that I might care about more or less? So really, it's all a matter of taking stock up front. What data sources do I have available? What are my priorities out of those data sources? What really aligns best with my goals? Throw them into the funnel, layer in some additional logic based on your priorities, and land on a strategic attribution algorithm that you can then run in real time to make sure that your assignments are appropriately aligned. So putting that in a little bit of context, we've laid the groundwork, right? Supplied, derived, but how does that look for a lot of the clients that we work with? I mentioned building an algorithm. The first component in our approach to that algorithm is what we refer to as provider rules. So before I even look at those supplied or derived assignments, are there any basically guardrails that I want to put up for the kinds of providers I actually want to tag to patients? Because some are probably more relevant than others. Very common one that we see organizations put into their algorithm is a custom look back period. So I could say I might have an EHR assignment, a plan assignment from 4 years ago. Could be helpful, but I might actually just want to filter the providers to anybody that has either had an assignment or an encounter, let's say in the last 24 months. Because again, if we tie it back to the themes at the start, we're trying to find the one person that is actually engaged with the patient and positioned to drive successful positive outcomes. So it can be helpful to focus on a more current point in time to make sure you're getting the right providers in the mix. Some of our clients will layer in sort of specialty criteria as well, making sure that they're only pulling in providers for assignments if they, are rendering internal medicine, family medicine services. Data can be a little bit convoluted. You sometimes see people assigned to specialists when that might not be the right assignment. So you can limit to PCPs, or some of the specialty networks we work with actually do want to assign to specialists. And so that's something that we can play around with as well and be flexible. Some clients will layer in criteria around network status. So I might say, I'm only tracking the providers in my network. The reports I'm running are only pulling in those providers. So let me add in a filter to only assign patients to those individuals. Or alternatively, go broad, assign to everybody, and then just kind of tailor your reporting from there. And then source prioritization. That one can be really helpful as well, because as we all know, health data is variable and finicky, and your priorities, again, vary based on the reports you're running. So that might be something where if I am a client and I have an employee health plan that I manage, but I have a lot of other data sources too, I might say, you know what, I want to look at assignments or encounters coming in from that health plan before I look at any other data, because that's my top priority. So if I see an assignment there, boom, I'm done. That's what my algorithm picks. I don't look at anything else. But then if I don't have it, then I still have an array of data sources available to me that I'll look at as the second tier. Or the flip side of that, we'll have some clients that might have a clinical source where historically data quality has been a little bit spotty. So I might say, let me look at all of my other sources first, because I don't really want to rely on that. But if I don't have anything in another source, I don't want to throw that clinical source out. It's still data. It's still usable. I just want to kind of put it at the lowest tier of the source priority to make sure, again, that we're really targeting the most appropriate providers. And then once you set those provider rules, those provider guardrails, that's when the supplied and derived assignment information that I talked about comes into play. So you can kind of start prioritizing, do I want to look at plan assignments first, whether that be at the PCP or maybe even practice level, depending on priority. And then start looking at clinical variables, or even take a step back, and just think about who has the most visits, who has the most recent visit. Do I have visits tied specifically to primary care services or physical exams? That's a really common one. So the takeaway here, or even upcoming appointments, that's something you can layer in as well if you have appointment data. So again, all just thinking about what data do you have and what are your priorities with that data, and then how can I sequence it appropriately to make sure that I'm really targeting. Again, I'm going to keep reiterating the message out of that broad network of stakeholders. Who is the person that is best positioned to drive patient outcomes and performance success? And then to wrap it up, I just put this in perspective a little bit, maybe an example sequence that a client could pull together with some common ones. So again, scenario here, I've set those provider rules. My look back is 24 months, focusing to primary care, or internal medicine, family medicine specialties. And now I run through my sequence. So first and foremost, a popular one is consensus. Do all my claims and clinical sources agree? If so, probably a good indication that someone is engaged with that patient. So boom, done, aligned PCP, no further logic needed. But maybe I don't have an aligned PCP. And then a common sort of secondary source of truth is plan assigned, since we said it's sort of the closest thing to an externally supplied source of truth that we have. So if I have a plan assigned provider, boom, done, plan PCP. If not, that's when a lot of clients will start layering in the derived or sort of event-based logic. Have I seen a recent primary care service in my data in my look back period? If yes, great. If not, a lot of clients will layer in a sort of like a final, just purely encounter-based step before I throw my hands up and say, fine, I don't have enough data, the patient's unassigned. So basically, have I had anybody with a PCP sort of background or specialty see the patient in my look back period? And maybe that's my sort of final catch-all. So to wrap it up, takeaways similar to the start, right? This is not simple. A lot of different stakeholders, a lot of different data sources. But I think if you really approach attribution with that lens of understanding what are my priorities, how do I want to match up these people in a way that really best positions me to succeed in population health and also contract performance, both of which are really important and can be married together. That's something that we do very often and we see clients succeed with.